Hi, everyone. This is Janet Guptill, the Executive Director of the Scottsdale Institute. We're so pleased that you're all here today. This is a vitally important topic. We've been having a lot of conversations within Scottsdale Institute about unique collaboration opportunities to really position our health systems more strongly in their markets, but also to address some of these really thorny issues. No bigger one is price transparency, ease of patient payment. And we're excited to have this particular conversation that will highlight a unique set of experiences in the Phoenix market. I'm going to share my screen just to begin to introduce the topic for today. And then what I'm going to be turning this over to is not only the speakers that you'll be hearing from, but first I'd like to kick it off with Tom Sadbury, who is our vice chair. He's going to introduce today's speakers and get us kicked off. So Tom, thanks so much for being here today.
Thank you, Janet, very much. And I want to welcome the panel members as well as the attendees at today's conference. Since Scottsdale Institute was founded in 1993, the three key pillars that we have tried to employ are education, collaboration, and networking. And based on today's timely topic, the nature and the background of the speakers that we have and the organizations that they represent, I'm very confident that these objectives will be met. Given the historical tension between health systems and health plans that permeated not only the Phoenix marketplace, but really throughout the country, it's really refreshing from my perspective to see examples of collaborative partnerships that benefit both the providers, the health plans, and more importantly, the patient/consumer. And I'm sure you'll see several examples of how this collaborative that we'll be discussing today do that. I had the benefit of previewing the slides before today's presentation, and words like collaboration, flexibility, and most importantly, trust, I think are foundational to the partnership that you're going to be hearing about today. Let me introduce the three speakers. The first speaker is Doug Watson, who's Chief Financial Officer at Dignity Arizona. I think you all know that Dignity is one of the largest, if not the largest, Catholic and nonprofit system in the country. Dignity Arizona is over $6.5 billion in net patient revenue. Doug received his bachelor's degree from Chapman University in California, is a CPA, joined Dignity back in 2017, has a very diverse background, both with health systems, as a consultant with physician practices, and with health plans. Our second speaker will be Paige Rothermel, who's the Chief Operating Officer of BlueCross Blue Shield Arizona, been there almost 3 years, which serves 1.9 million customers and growing. She is in charge of IT and all business segments within the BlueCross Blue Shield plan of Arizona. Prior to her coming to Arizona, she had over a 30-year experience in Anthem in California, where she served as a vice president. A theme of her career has been growth, change, and customer relations. Paige, among her other community activities, is a member of the Phoenix Art Museum Board, which is near and dear to my heart because our daughter Rachel has been an assistant curator there for the last 7 years. And then last but not least, Paul Briggs, who's a CFO and Senior Vice President of HonorHealth, a $2 billion organization, which is a result of a merger 8 years ago between John C. Lincoln Health Network and Scottsdale Healthcare, is served. He joined them not too long ago, but had a robust history with several different kinds of organizations. I had the pleasure of knowing Paul when he was in a similar role at Presbyterian Albuquerque in New Mexico, which is not only a preeminent health system in New Mexico, but also has a very well-established health plan. At last count, had over 500,000 members. So Paul is also a CPA and received both his bachelor's and master's degree from BYU in Utah. So without further ado, I'd like to turn this over to our speakers, and I'm sure you're going to be educated, and there'll be time for a robust discussion after the presentation. Thank you.
Thanks, Tom. And we're going to start off with Doug Watson at CommonSpirit. So thanks, Doug.
Great, thank you. This is an exciting opportunity to be able to share a little bit with my colleagues here on the panel, but also with everybody there in the audience. I think we're very excited about what we were able to do. Let me just spend a minute about CommonSpirit Health. CommonSpirit Health is the combination of Catholic Health Initiatives and Dignity Health. We came together 2 years ago to form CommonSpirit. We are one of the largest not-for-profit health systems in the country that is mission and faith-based. And we started working with OODA, which is the OODA Pay platform we're going to talk a little bit about several years ago, and really connected with the idea of trying to think about what we could do differently to get a better patient experience from our perspective. You'll hear later that correlates with a better member experience on the health plan side. And we currently have that deployed in our main hospitals here in Phoenix, and then also in about 26 hospitals across California. We rolled it out dually in Arizona and California. The California facilities are using a BlueCross Blue Shield plan in California, and in Arizona, we have partnered with BlueCross Blue Shield here in Arizona. So if you go to the next slide. I want to share a little bit about why we wanted to do this. I don't know if the slides are moving, but there we go. Actually, I'm sorry, before we do that, let's make sure we have an opportunity to talk a little bit about the 3 partners here that have been doing this here in Arizona. So Paige.
Thanks, Doug. Appreciate the opportunity, and good afternoon, everyone. I am thrilled to have the opportunity to join 2 of our provider partners who have been on this innovative journey together as we look to implement OODA. A little bit about BlueCross Blue Shield of Arizona. We are a single state Blue plan. That means we only operate within the geographies of Arizona, with the exception of how we partner with other Blue plans across the country. We serve about 1.9 million members and have about 2,600 people who work for us here in the state. And we're in all lines of business and have the opportunity to serve Medicare, Medicaid, and the commercial and individual markets. So with that, I'll turn it over to Paul, who can talk about Honor.
Hi, Paul Briggs from HonorHealth. Really pleased to be with you this afternoon. We are a nonprofit local community healthcare hospital system, and we serve an area, primary service areas, about 1.6 million people. We currently operate 6 hospitals: medical group, outpatient surgery center, cancer center. Have an excellent accountable care organization, and one of our hospitals just opened up in North Phoenix, Sonoran Crossing Medical Center, this last October, which is our latest addition to the organization. About 12,000 employees, and Mr. Sadbury knows a lot about HonorHealth, as he was one of the key architects of bringing together Scottsdale Healthcare and John C. Lincoln Health Network as it was formed by a merger. So I'm really glad to be with you, and I'm probably the newest to both Phoenix and the OODA Health experience, but looking forward to the conversation.
Doug, would you like to give us just a little bit of background about OODA Health and then how you got to this point?
Sure. So OODA Health is a venture type of an entity that's really trying to do a technology platform. We in CommonSpirit found it very interesting early on, and we're an early investor, as was BlueCross Blue Shield of Arizona and Blue Shield of California. And we really set out with the idea of trying to create a different way of approaching payer-provider connectivity. What was really refreshing, I remember some of the early meetings and thinking, wow, this sounds really great, but it'll be impossible to do, because we'd all been down the road of trying to make these things happen before, and usually you end up hitting the claims engine and hitting our revenue cycle billing engines, and you kind of give up because it's just so hard. But we were optimistic we'd be able to think of a different way, and working with a group like OODA that came to the table really from a technology perspective, and not necessarily from the perspective of having come from within healthcare. So trying to look at it from a different way of thinking about things. And they've had input from a number of folks across the country, because the goal is to try to create a platform that, for want of a better term, can really be applicable across multiple payers, multiple providers, and create something really useful for a patient. And I think certainly in the work we've done, we've seen some realization of that dream. So what did we come together? And I still remember some of the early meetings where we got in a room with OODA and with Blue Cross Blue Shield of Arizona. And, we were talking about what was possible. And again, I think we all came to it with a healthy level of skepticism, because we've all tried these things before and it's always been more challenging than any of us thought possible. But we agreed on a few things that were very clear. One was healthcare needs to be more affordable. That's a goal that Blue Cross Blue Shield of Arizona shares. It's a goal that CommonSpirit shares. It's a goal that HonorHealth shares. We also felt that the financial burden of patient collections, and it's not so much the burden of actually collecting the money, it's all the administrative cost of trying to collect the money. And trying to figure out how to make it easy for a patient to pay when they want to pay. And in most cases, patients want to settle their financial obligations. They often struggle trying to figure out what they owe. That was one of the things you'll see in a little bit that we tried to address, was make it easy. Because, when they get one statement from an EOB from an insurance company, and they get another statement from us, and then they get another statement later on that applies part of that, and they end up with 3 statements that say different numbers, they don't know what to do. And this solution helps us solve that. We also want to build on trusted partnerships. Certainly Dignity and Blue Cross Blue Shield have had a long history of working together. We thought there was a willingness on both sides to figure out how to solve this in a trusting way. And I will say, if you try to solve problems like this and you don't have trust between the organizations, you won't get there. Because we had to trust each other and open up how we did things and some of the magic algorithms behind the fence. And because that's the only way you get things to do what you want them to do. And then the last part, which is something that really was refreshing, and this certainly is embodied in what we try to do. We call it hello human kindness. We have a different word for it. I know Paige has a different word at Blue Cross Blue Shield, and Paul has a different word at Honor. But we all really care about our patients, and we want something that's going to delight them at the end of the day. Paying your bill is never a delightful experience, but it can be a much more pleasant experience and a much better experience, and hopefully not be a negative in any way. And actually what we found is patients really love this approach. You'll hear more about that later, but they actually really like it. If you go to the next slide. Most of you are familiar with what you experience in other situations. So the last time you wanted to buy groceries, chances are you went online or you went to your phone and made your grocery list, told them when you wanted to come pick it up, and picked it up. Went to McDonald's, you probably ordered your stuff, or certainly at Starbucks. I always order my stuff in advance, so it's waiting for me, and they've already charged my card through the system, and I'm done. In healthcare, we have a few portals and a few other things that all of us have tried to develop, but we're nowhere near where this experience is in most other industries. And patients are consumers, and they are starting to expect that it will be as easy as booking an airline ticket and catching a flight when they come in and have a procedure done. And we need to try to make it that easy, because it's a win-win for us, and it reduces the administrative costs of the program, which is a win for everybody. And it makes it easy for the patient, which again is the overriding goal. So if you go to the next slide, the other thing that patients experience is this deluge of bills. You go in for a procedure and you get multiple bills. You get a bill from the hospital. You often get a bill from some of the individual physicians. If you went to the emergency room first and then ended up being transferred to another hospital, you've got yet another bill. And then you get an EOB from the carrier. In some cases, if you have other insurance, you may get several EOBs. And it gets really hard for a patient, particularly an unsophisticated patient. Even those of us in healthcare sometimes have a hard time deciphering all the bills and figuring out exactly how much we should pay at the end of the day. And as the statistic shows there, often what the bill from the provider shows is not the same as what the health plan is saying they owe, and the patient isn't sure what to do. And that's one of the things we wanted to set out, was to be able to come as close as we could to a single source of truth for that patient, so they knew what their obligation was, they could take care of it easily and move along. If you go to the next slide. One of the questions that OODA was asking is, and they were talking with us as well, as we were saying, well, where do we start? When you want to make things simpler, where do you start? And one of the places that really early on came down to was this patient payment issue. And part of it's because most patients rate the post-visit phase. And those of you in the healthcare provider sector know this. That patient leaves your office as a provider or leaves the hospital. We've often done great work with them. We've improved their health, hopefully. They leave very satisfied. They do a customer or patient satisfaction survey on their way out. It's pretty high. A month or two later, when they get the form from Medicare or from whoever else is asking, or our patient satisfaction vendor who's doing the survey, they've had a chance to come back down off of that a little bit because they've gotten a bill. Perhaps they didn't understand it. Maybe they felt like it wouldn't work. It was frustrating for them. So there was a big letdown afterwards with post-visit activity, all this administrative stuff that they had to deal with. And it matters to patients. As we did survey, and OODA led this, but as they did surveys with patients and just talked to them, one of the things they said was, yeah, this matters to me. If it was easier and simpler for me to do, I would consider using a different provider. Not everybody believed that, but it's really true. And then in some cases, patients now, and I think we'll see it being much more than 1 in 5 soon, will just stop dealing with somebody who's too hard to deal with, right? They want a good digital experience because they're getting used to getting it. You'll shop at a grocery store that makes it easy for you. Well, you'll go to a provider that makes it easy for you to a large degree, particularly for routine things. When you get to the very high end of needing brain surgery, I think perhaps your sensitivity to the digital experience goes down. But for the day-to-day activities, very, very high on the list of things. People are busy. They don't want to have a huge hassle. They want it easy, and they want an easy front door to get through. If you go to the next slide. This is a quote that that got picked up and I appreciate, but it really summarizes what we set out early on and really experienced is as you try to flow the claim through and you think about it, comes out of our system, goes through a clearinghouse, comes into the BlueCross system. It's the systems themselves are not very flexible, and a lot of our folks are not used to thinking outside the box because they're used to working within the box, right? I mean, they've got to figure out how to get the claim to go and how to get it through. And so we had to step back and think about doing things in a different way, not the least of which was sitting around a table with both us and the health plan and talking about it and looking at it from, well, this claim did something weird in our billing system when it came out. We didn't know it was going to do that. And oh, wow, the clearinghouse did something to that claim before it hit Paige's system. And wow, Paige's system did something to that claim before it came out on the EOB. Well, we'd never sat down in a room and really understood that together before, and then tried to think about, well, okay, how do we make this work in a way that we get where we want to go together? So it was a creativity and I think just a willingness to trust and say, yeah, we're going to have to share some things. Quite frankly, while we might sometimes think that our billing system is proprietary and it's somehow a competitive advantage, it isn't. It's a way of getting an administrative process done. The competitive advantages and things are all in the experience that people have. And so we had to really open up and do that. And I think it was probably one of the biggest successes of the whole program was the fact that we really talked. We really sat down and figured out what is the patient experiencing, what's happening through this, and how do we make it better together. If you go to the next slide. OODA Pay, the implementation. So I just want to share a little bit about what the heck it is we're talking about. So basically what the OODA Pay billing platform does is the patient comes into our hospital or HonorHealth hospital, or as we continue to roll out, could come into an ambulatory setting, could come into a physician setting. Immediately after the claim processes, OODA assumes a responsibility for the billing and collection activities with the patient. But they're doing it in collaboration with Blue Cross Blue Shield. So when the patient gets their first bill, it's connected to the EOB that says, this is really what you owe. This is how it's been adjudicated. And ultimately, they're going to be paying through to Blue Cross Blue Shield. Again, that creates a very different dynamic in the mind of the patient. And it also creates a credibility around the number and about the transaction. So that's one thing that I think was a real benefit of it, is it took that ambiguity and lack of clarity away for the patient, because now they knew this is the single source of truth. This tells me what I actually owe. If you go to the next slide, The other thing that it does is it changes the patient experience in a way that the patient can now use whatever form factor is most comfortable to them, whether they use their phone to look at their bill, to look at the EOB together with the bill, determine how much is owed, and then decide how they're going to pay it. They can either make a payment right away, nice and simple, just like you do with Starbucks, or they can enter a payment arrangement. We're a faith-based organization. Obviously, any not-for-profit and even for-profits have certain requirements around charity care and other things. So we had to work through that as well to make sure that by the time this got to this point, that we knew that this patient, in fact, could pay and follow all the rules that you have, both in terms of legal requirements and regulatory requirements, but also our own corporate requirements, because as an organization, we have higher requirements in terms of what we're willing to do as charity care, et cetera. So we had to build all those sorts of things into it so that when this came to this point, and we still have within the system an ability, if a patient says, look, I can't afford this and I can't afford the payment plan, there's a way for it to then move into another opportunity for us to reassess that question again. But it really mimics very much the sort of way people are experiencing healthcare, experiencing other business functions. It's very easy. It's convenient either on their computer or on their phone. Now, why did, we did this, and we did it initially as a pilot to try to say, hey, this is going to work. I mean, and will anybody care about it? And what we found was, first of all, it improved the speed to collection. So the fact that that we didn't have the 2 or 3 or 4 months while the patient tried to figure out what they should pay. And quite frankly, we trained everybody not to pay on the first bill, right? I mean, that's something we've taught everybody over the years, because if you pay on the first bill, then the insurance finishes paying, and now I've got to give you a refund, and it takes me a while to get you a refund because of just the mechanics of doing it. We taught people, don't ever pay on the first bill. So by having a single source of truth with a final adjudication that makes it clear, people paid a lot faster. They paid more in general because it was easier for them to do it. And if they needed a payment plan, they could do it. And the payment plan was easy for them to follow and stay with. So overall, there was more money ultimately in total that could get collected. And then patient satisfaction. I was really surprised when we started to see, I thought patients would like it better. But if you look at it objectively with the patient satisfaction data, it's striking. They really like it a lot better. And then we also get about 93% engagement with the patients. So there's 7% of the patients who are really perhaps not quite getting engaged with this, and there may be a myriad of reasons for that. But 93% of them connect either by the phone or the web and take care of their bill, and not just the one time. I mean, they're checking it periodically. They're creating interaction, which is one of the ways in mobile that you can tell whether it's working, that we really are getting that connection. So we thought it was very successful as we saw these sort of results in the pilot, and then now as we've rolled it out into production for the last year, we're still seeing it. It's sustaining over time that is in fact a better experience, and they like it better. So that's our point of view from a provider perspective. Let me ask and turn things over to Paige to hear a little bit of why this was important and of value to Blue Cross Blue Shield of Arizona.
Thank you, Doug, and I appreciate the opportunity to share our point of view. And it's so great to hear your story about how we got here and the collaboration between the 2 organizations, which is now 3 organizations and continuing to grow because of the interest. I will just say that the partnership built on trust foundationally is about communication. Typically payer-provider relationships, we have to look past certain historical approaches to how the 2 organizations work together in order to be able to innovate for the future. What Doug, you talked about was this focus on the consumer and understanding that consumers' expectations of us as an industry are changing. Pre-COVID, changing, but post-COVID even more, with virtual care, other opportunities for us to really engage in our health using the tools that consumers have become so familiar with using. And the fact that we are not there as an industry is a challenge. So the only way we resolve this is we come together and we think outside the box. And that's what OODA helped us do through this process. If you think about the focus on the consumer experience, and if you were to pay your even your electric bill, your cell phone bill, whatever bill you're paying, at some point, you don't have the level of complication of bringing together two different entities and trying to figure out what that bill should cost, right? And the number one complaint we as a health plan get is the fact that the EOB does not match the provider's bill. And so we get calls every day into our call centers asking us to explain the differences. And so this OODA solution really does take that totally out of the equation. It creates what we like to call a graceful consumer experience, because it helps that consumer get through their whatever their care incident was, the experience they had at the hospital. They come out and now they continue to have that positive experience because we've taken that burden off of them in trying to understand what their bill means. The other thing I would say is that it does take, in this scenario, to get an effort like this off the ground, it does take leadership support from the highest levels of the organization. There's many conversations that Dignity and the payer, Blue Cross Blue Shield of Arizona, and I'm sure California's Blue Shield entity had the same conversations, where it does take a different way of creating payment models back and forth, different financial models back and forth, and it does require that type of leadership support to move that forward. And I can't stress enough the fact that when you think about creativity, we are breaking down barriers here that have been institutionalized since the introduction of Medicare in, I think, 1960. So what we have really been doing here is looking for those people in our organizations, or both organizations, that have a desire to want to do something incredibly innovative and change the mindset that what typically is the role of the provider versus the role of the payer is not necessarily accurate. And we can actually eliminate administrative waste by doing this. We can get more digital engagement. And if you think about digital engagement and our future, it's so critically important for us, not just the billing process, but everything related to people's health or making appointments or any of the normal healthcare types of activities that our customers or our consumers look to us to do. We're going to want to have them connected in some way digitally, so that over 90% engagement rates are critically important as a plan for us as well. We can go to the next slide. And thank you, Janet. And I just would like to say that one of the things that really, I don't think it surprised us as much as it really delighted us. It was, we knew that we were doing something different when we embarked on this journey to bring together this problem, or to solve this problem. But by talking to our consumers and learning about the complexity that they've experienced, especially those that have complex health conditions. Chelsea is an example of a real member who had basically 10 years of dealing with the piles of papers, EOBs on one side, provider bills on the other, trying to match it together, not knowing what to pay. And then she got pregnant and she had this wonderful experience. And we've actually got a video that we will post for you after this session for you to see. But it will give you the opportunity to hear directly from a consumer who's experienced this. And I do think that we did delight her. We provided a graceful experience, but she also was quite emotional in how she responded. And I think it's worth a listen if you have the opportunity to do so. So with that, I'm going to introduce our newest partner in this work and the OODA pilot, and that is Paul Briggs, who's going to talk about our most recent implementation. I think we went live, Paul, March 1st with
Yes.
OODA, and would love to hear your perspective. So with that, I'll turn it over to you.
Okay, thanks, Paige.
Sure.
And next slide. I appreciate Tom's introduction into this, where he called out the words collaboration and trust, and these are different kinds of conversations that we're having with Paige and her team, and even with Doug. Doug was one of the first people that I called when we were considering OODA, and he was very gracious and candid about kind of the challenges and the whys and where they were. So, you know, we have really focused on and liked having a different conversation about the patient and the member themselves and what kind of experience that they should really have. So we teamed up with Blue Cross and Blue Shield of Arizona, and we are, as Paige said, right in the first part of implementation. And we started on March 1st. I'm happy to say that I have not had a single complaint since March 1st. So I'm assuming 100% satisfaction in the last week with this product. But if you think about all the progress that's been made on the electronic interchanges between health plans and delivery systems, most of it's been based on the back and forth between health plans and delivery system, and the patient has clearly been kind of left out. They're just in the middle, trying to sort through, you know, what is really happening with the delivery system, what is really happening with my insurance company. As Doug said, you know, one of the first things that typically we send out is something that looks like a bill, but then says on top, this is not a bill. And I know everyone has, you know, experienced that and is confused on that. So, you know, I think this is a really important start to technology that will really assist in the patient and member satisfaction. We do use an Epic single billing office, and of course, you know, we focus on clean claims and trying to get those through as quickly as possible. But this really provides us a additional value in terms of a single call resolution center, and someone being familiar with the actual benefits and the health plan, really assisting the member and the patient through that. We found the implementation with OODA to be and teaming with Blue Cross to be not simple, because there's a lot of complexities in here and there's a lot of learnings on the way, but felt very supported in bringing this up and starting the implementation on this, both from Blue Cross and from OODA. And so I want to talk a little bit about where we're headed. You know, Blue Cross Blue Shield is a great partner of ours, and we are trying to take a look at different kinds of insurance products, and along with these kinds of technology. We'd also like to expand the technology into some other areas, you know, helping with pre-service patient engagement and prior authorization, and just in general increasing the coordination in terms of patient support and customer service. And of course, as was mentioned, a lot of this has to do with tremendous administrative costs that we incur and Blue Cross incurs, Dignity incurs, in terms of trying to coordinate the billing and collections. And so we see that as a real plus as on other kinds of efforts as we head into the future. Next slide, please. So the way I'm viewing this is we're kind of off to a good start, but we're really only at the starting line if we look at our whole patient population. And right now we're working with the Blue Cross Blue Shield commercial patients only. But of course we have many other contracts. We have 90 plus other managed care contracts, self-pay patients, government payers that we work with. And so we're trying to think through and sort through, you know, how can we expand and assist other kinds of patient populations with this innovation and this technology. Healthcare billing, I think we'd all agree, healthcare billing and collection and payment is a mess, and so it's just building complexity upon complexity, and we have a lot of people trying to assist on both sides of the table in terms of Blue Cross and HonorHealth, but the automation is just a mandate, and we've got to automate and make the experience simple, clear, easy to respond. We know if we get it right the first time through OODA, if we have the information right, that we're much more likely to get appropriate payments and settlements on these these amounts owed. And we are looking at other kinds of digital interactions. We have payment mechanisms through our Epic electronic health record, which is a real plus for our patients. We want to see how we can kind of integrate the work we're doing here with MyChart and that electronic health record to make it simpler for patients, so they can identify, you know, the pathways they need to go to take care of their financial obligations. And then of course, as we look to the future, I think thinking through how do we work more seamlessly between health plans and delivery systems in terms of standardized or simplified contracts, so that we can you know, better serve the patient through these advances in technology. Because if, you know, we need to change the processes on both sides up front, and how we're looking at contracts in order to make this highly successful. So going to the last slide. So we do have a shared vision. We're appreciative of working with OODA, and of course value our relationship with Blue Cross Blue Shield. We want to have a future where patients and members have increased trust. They don't question as much. They're not as confused about the bills that they receive. They're not sitting down with 2 stacks of EOBs and bills and trying to match those up. They have a single point of contact for kind of resolution of their issues. That's much easier to say than actually do. But I think OODA has brought to the table, and the collaboration has brought to the table, at least at the start of a pathway to kind of get there. And I think payers and providers are gonna have to work on this more specifically over time. Alignment, cooperation, creativity. I know from past experience, even when I was with an organization that had a large health plan, large delivery system, there was still a lot of interfaces that needed to happen in a better way. So we're really focused on that. We do view this as a platform for future innovation and some of the kind of pre-services and prior authorization. So I think this is a great start. I think we have a lot of work to do in terms of making the experience better for our patients, and of course achieving the goal of frictionless payment and billing for delivery systems and health plans. So,
Paul, one thing I would add, just based upon the comments and the experiences we've had so far, the power of this is really in the expansion of it, right? So that's one of the reasons we were so thrilled to have HonorHealth join in this effort. And besides the fact they're a great organization, but if we can have more patients that are able to have all of their bills come through this mechanism, now it really is much more powerful for them, because if they have a procedure done at HonorHealth and then they come and have another procedure done with us and they're having a tough year from a health standpoint, with OODA, they'll be able to combine all that together, end up with one payment plan, and not have as much just confusion of trying to figure out, well, this was them, this was that. You know, meanwhile, they can just focus on, okay, I've got one payment, it all gets sorted out on the back end, and I can focus on getting healthy, which I think has tremendous value. And we're going to see that too as we've started to bring on providers, so the physician side. So again, you can end up with a situation where a patient comes in for a procedure or something, and they ultimately get this all done, both them, the anesthesiologist, the surgeon, the ED visit, the post-acute eventually, so that all of that can come together in one place for one bill. And more importantly, bring it together for one payment, so that they don't have to make 6 different payment plans that they're trying to manage when they're trying to get themselves healthy again. So I think the power in this is one, some of us had to get in there at first and try to figure out how to make it work together. But the real value of this now is let's get as many folks onto the platform as we can, particularly ones where we're working together, where a patient's likely to interact with one and then another in sequence. How can we try to get that ecosystem together?
I just make one final comment. Appreciate that, Doug. And a final comment on the importance of this to HonorHealth. Obviously, the last year has been very taxing on delivery systems, with the pandemic, et cetera. This particular technology was prioritized and completed the implementation during all of that. So I'm sure most of all delivery systems have done is they've had to kind of prioritize and focus on those that are most important to them. And this came to the top of our list in terms of something we really wanted to do to help and to support patients. So I'll stop there. I think Tom or Janet is going to kind of help us with the Q&A.
Yep, great. Well, thanks. That was fascinating, and appreciate you all taking the time to explain not only what you had in mind, but what it took to pull this off and what you're seeing so far. Really, really valuable. And I'm going to remind everyone that is on the call, now's a great time for you to join the conversation. You can go to the part on the bottom of your Zoom screen where it says Q&A and just type in your question or comment, or you can actually click on raise hand and I can identify you and call on you. And we appreciate you joining the conversation. We do have a couple of questions that are in the Q&A already that are sort of around the background of OODA and how this works. And maybe just, Doug, if I can ask you to explain just a little bit, when you first described OODA, Neil Pickett from IU Health, who's on there, who's the chief of staff to the CEO there, is asking a little bit about what is OODA? Was it a separate company or did the partners create it? And then there'll be some follow-up questions that he has about getting it up and running and how long it took. But can you, Doug, perhaps first start on that?
Sure. It is a separate company. Now, it did come out of discussions with a lot of these partners and a number of us. CommonSpirit was one, BlueCross Blue Shield of Arizona was one. We're part of the founding group that helped finance it. So, we took an investment position in it because we believed it really was an idea that was worth pursuing and wanted to help make it happen. But it is a separate company, and we now still have obviously an ownership investment, but also a contractual relationship with them. Partially that we felt was important when we were originally thinking about it, because if it was 100% owned by us, Dignity, CommonSpirit, or 100% owned by BlueCross Blue Shield, it becomes difficult for others to join and for it to then be something that truly is embraced by other organizations. So we have an ownership interest, but we don't have, anywhere near control of it. But we are able to then be collaborative with others. And I think, I know they're working through as they're growing. I don't know if there's opportunities for other folks to invest as we go forward, but it was important that it be an independent company and not a subsidiary of one of us, because again, the goal is to really be able to get adoption and to be able to get that network to work amongst all the players that would be involved for that patient. Paige, I don't know if you had any other thoughts. I know you were in, your team was, your organization was in right at the beginning as well.
Yeah, no, Doug, it is, of course, an investment opportunity for us. And I agree with you. I think, I don't know that we would have been as successful in getting this up and running and making the kind of decisions together that we needed to make in order to think differently about the revenue cycle work, had it not been a third party helping us get to the bottom line. But I do think we kept our true north the whole time we were going through this, and you can certainly chime in here, but the true north was always about solve the number one problem for the customer or the consumer, and never let the way we were thinking previously get in the way of that. Mm-hmm. So, and OODA really did bring some great minds to the table to help us with that. And I think that got us to where we are today. And I think there was a question about how long it takes. And I would say it took us a little bit longer because we were first, right? So the two of us had to work out our kinks. And so I want to say though, Paul, that our implementation for Honor probably was less than 6 months. It was less than 6 months.
Yeah, I think there was about 12 months of conversation.
Yeah.
12 months of conversation.
That's the hard part.
Going back and forth.
Yeah.
But once we got to the implementation, it was right at 6 months from start to finish. And of course, we're still working on that. But we found once we got to the implementation portion, involved a lot of people, and of course IT and revenue cycle, but was a little bit less than 6 months.
Yeah.
And it was about 6
Neil-
months, I think, for us to do our original pilot.
That's-
But we went through a
okay.
pilot process because we had to, make sure things were going to work before we, started involving large numbers of patients. Because, as you might imagine, from both our side and BlueCross Blue Shield side, these are real live members and patients. We've got to make sure that whatever experience we give them is good. We don't want to have something go bad. And so we were careful as we went through the pilot. Now, as it turned out, it was a phenomenal success. And in fact, we started to move rapidly into trying to deploy it faster once we proved it out. But there, obviously the first time around, it takes you a while to just figure out what's going to work and what isn't going to work.
Yeah, and we added hospitals. Adding a new hospital to an existing relationship takes no time. A new partner, maybe a little bit more time, but that's what we did in order to get scale. We also looked at different lines of business. You notice Paul called out the fact that we started with commercial business, but looking for ways to bring in other lines of business into the conversation as well, or into the work. In addition, it started with a hospital-only relationship. Now we're looking at bringing physicians and hospitals together. So if you think about a consumer, they go into the hospital and they could potentially get 8, 10, 15 different bills from different providers for the same incident. So or the same admission. And so to the consumer, it's overwhelming. And so the more that we can bring those things together, and give that patient one experience that they can then, of course, set up a payment plan and or pay all at once. It does take the complications out of it for the consumer. So that's another great way to expand it.
Absolutely.
And Neil, did you have any additional question you wanted to ask directly about sort of the lift that it takes to get this up and running?
Well, just really quickly, just wanted to know if it had to be an Epic platform, or do you have Cerner work on this? And then secondly, I'm really curious, do you see this as facilitating different kinds of strengthening relationships between the health systems and DCBSA in terms of other kinds of projects and focused on maybe on patient care and improving outcomes, for example?
Certainly on the first question, I think the platform, we're Cerner. I know Honor is Epic. We actually had within our hospital base 2 different billing systems bolted onto Epic. And so we were able to make it work with both of them. So I think it will work. We certainly had some, different nuances as we tried to do the different platforms, but that certainly didn't prevent it. So I don't think platform is really an issue.
Yeah, in terms of other kinds of things that we have been focused on the electronic health record to kind of communicate and direct some of the things in terms of patient care that you have talked about. So I don't think we're trying to rely on this for for that kind of relationship, rather to smooth the the financial experience and then somehow integrate that with our MyChart platform.
And I agree that this was really focused on administrative connections, but there are some administrative functions that touch the consumer and also touch doctors and physicians, and that is things like prior authorization. And now that we've got these connections going post-service, OODA is working on looking at ways to help facilitate more real-time connections between us and the provider partners to say, how do we get some of the abrasion away from pre-authorizations, pre-certifications from a hospital perspective, get a little bit more real time in order to be able to get speed to care for everyone, and also reduce the administrative waste and the angst. If we're approving a very large volume of pre-certs, do we really need to pre-cert? Is that kind of thing that we've been working on together. And OODA does have an interest in looking for ways to continue to expand their relationships or their role in that space.
Great. Thanks for that. And thanks for your questions, Neil. Dr. Michael Shabbat, who's also a board member at the Scottsdale Institute, raises the question around, and I think you've already addressed it, but sort of you've been talking about the hospital bill management, but does it extend to patients even from independent physicians, so even physicians not affiliated with your organizations. And did I capture that correctly, Michael, or is there any elaboration you want to make on that?
Just a bit of an elaboration. Frequently patients receive bills from contracted physicians, anesthesiologists, hospitalists, intensivists, pathologists, neonatologists, others that they didn't really pick, but were credentialed at the hospital, but they wind up getting an array, and this was, Paige, you've mentioned it, an array of independent bills, which adds tremendously to the confusion. And I would like to add, many patients and consumers, they don't understand the bills and the EOBs. And I've yet to meet a physician or hospital executive who could predict in advance what the EOB would be like for any particular medical service they've received, period. So OODA Pay is a great advance for hospital bills. How can it be extended?
Well, we are working on that with OODA. Now, the challenge you get, with moving outside the hospital environment is just simply scale. When you connect the hospital billing system, you get a lot of scale. When you connect a physician billing system, you've connected one physician billing system. So there's just a logistical scale issue that you have to work through. It takes you longer because there's more implementations required to do it. But I think the value prop is very clear because of just that. When we get to the point where all of the anesthesiologists, all of these hospital-based providers are on, and as we bring our medical group on and we bring affiliated medical groups along to it, I think the power of it just expands. Our top priority as a hospital was to work on our hospital-based providers because, again, for that patient, they are likely going to get a bill from one of these other ancillary hospital-based providers during their stay. And so to the extent that we can get them on, there's a big lift and a big benefit for the patient. So that's where we focused, and we do have several of those coming live here shortly.
Good.
Great. Thanks for your question, Michael. A follow-up question is coming to us from Brent Snyder, who's the Chief Information Officer at Advent Health. And he's asking, do you permit patients to pay on your patient portal? But also, what about paying bills on the platform with those independent physicians, again, that you just talked about? Maybe you want to elaborate on that, Brent, with your question. Brent, if you'd like.
My question was, these, I take it these accounts are still on your Epic system. So if people come into your Epic system, can they still make payment there, or is that disabled, so that they only go through the OODA product?
Yeah, we're trying to have the initial billing and interface with the patient through the OODA product. There are some complexities in here, and I'll just throw out, one kind of simple example is, if there's a non-covered benefit that comes out of this that we still need to build for, that will be done through MyChart. But we're still on the front end of thinking through that kind of integration and how that works with MyChart, so that there's information that flows back and forth.
Yeah, and that's the key to it, is you got to have that information actually flow. So, that was one of the things we worked on early on is, well, how do we share if the patient paid some money right up front? So they showed up, they paid some money. Well, OODA needs to know that, because they need to know when the adjudication from Blue Cross Blue Shield is done, they've already paid a certain amount of that money and they need to get credited for it. There's nothing worse than getting a quote source of truth bill that didn't include something you did, right? That'll aggravate a patient in a big way. So we had to make sure that information could flow. And then if we get a payment that just shows up, because sometimes patients will, just mail it in, or they'll drop it off. It's all kinds of interesting ways people try to pay. We had to have a way for us to capture that and then pass that information along so that OODA knew that didn't need to be collected or had already been collected. So there were some mechanics we had to work through on how to do that. We managed to find a solution that works within our billing system to do that. It may be a little bit different when you're looking at MyChart, but the concept, I think, is still the same. You have to have that flow of information, and it needs to be, as I stressed with our folks, it needs to be as real time as possible. So if that patient somehow pays in the morning, I don't want OODA calling them in the afternoon, right? You got to try to make sure that information flows as quickly as you can. It's not going to be simultaneous, but it can't be a batch operation that happens once a week or once every 2 weeks that it updates. It's got to be much more frequent than that.
And the last question, how do you handle secondary insurances?
Well, that's a good question, Doug. Can you answer that?
We're still working on that because, it could become quite simple if the other insurance company was on OODA with us.
Mm-hmm.
If not, it does become a little bit more difficult because we can, and Paige, you can probably talk to it better, but, Blue Cross Blue Shield can adjudicate their portion of it. But if there's a secondary that needs to also weigh in, sometimes we can handle that. Sometimes it ends up kicking out and we have to handle it manually.
Yeah.
And I would say that's we really are at the front end of trying to get this technology to work for patients. And what you're bringing up is a lot of the complexities that are still out there that we need to continue to work on.
No, I applaud for what you did. I just didn't know if you'd successfully worked through some of those nuances yet.
Great.
Thanks.
Thanks for your question, Brent. We have a question from Don Halliwell, who's a CFO at Carilion Clinic, and it loves the idea of what you're saying is the positive side about this, but are there any factors that might not be obvious that might detract from these kind of benefits, or a reason for a provider or a payer not to do this? And I don't know whether, Don, you wanted to elaborate on that in person.
Well, I think we've all been through, thank you, first of all, very helpful, very interesting. And we're doing a lot of work in this space as well, more on the back end of the process than the front end. So this is very interesting, but we all know, been through enough of these types of implementations to know there are things you don't realize until you've done it or you're in the middle of it that, sometimes are just bumps along the way, but sometimes could have influenced your thinking up front if you would have known them. So I just wondered if you encountered anything like that in the process.
Well, we certainly encountered plenty of cases where we thought we were going to do it one way and had to regroup and think about it because it didn't work the way we thought it would or something. And that's where I would say, if you didn't have that trust between you and the payer, I think you'd run into a big problem, because in some cases we had to come back and say, hey, this won't work and it's the way our system's doing it or your system's doing it. And had we just evolved into the typical, oh, well, it's your fault, you don't want to try hard enough, or whatever it is, you're going to end up having the whole thing fall apart. So you have to have that trust level and that belief that both sides really are trying to do the right thing for the patient, and we're going to try to figure it out, and that we're aligned on that. I think if you didn't have that, I think it would be very, very difficult. And then the other part is this actually does take work. Right? We had people in conference rooms for 6 months trying to figure it out. Now, there's a lot of learnings from that the next person implementing doesn't have to recreate all the things we learned. And that's one of the great things about the way OODA has tried to capture that and be able to engage that into the next implementation, et cetera. But the fact of the matter is you'll encounter something you don't know or that isn't going to work quite right, and you got to be willing to solve it. And that means you got to have your technical folks and your operations folks willing to spend the time, and you got to be willing to spend that time to really make it work. And that was a significant investment on our part. And I know it was also for Paige and her team, because, this took work. Real work to sit in a room and figure it out.
Great. One quick question from Steve Chen, who's a divisional CFO at Adventist Health. Did this reduce cost at any point? So have you been able to recognize any costs on either side? So I don't know, Paige, have you been able to recognize a reduction in cost from having done this?
So of course, we made a significant investment, so we've got to pay back the investment first. But yes, the intent was for us to be able to reduce the cost of mailing EOBs, everything related to the communication of phone calls, less phone calls, higher satisfaction. Hasn't been actually quantified yet, but I can assure you there is a reduction in the hassle factor for customers, and we're getting less phone calls as a result of this change. So yes.
Yep, and there's definitely, in some cases in our revenue cycle, there's substitution of costs. So, we had early out vendors and other things that we were paying. And so now instead of doing that, we're directing it this way and getting a better patient experience. We also, I know from talking to my patient relationship folks, have far less situations where they're getting called by Blue Cross Blue Shield patients about why did they adjudicate it this way and why do I owe this? Which we of course can't answer because I don't know why they did it. We don't have insight into their system to go back and see. We've got to then refer them over to Blue Cross Blue Shield. So now we've got a patient who's frustrated and we've got 2 phone calls and 2 people trying to figure out the same problem. And we've eliminated that. And when I talk to our folks, they say, wow, we've really seen a reduction in this kind of activity. Now we can, spend our time doing other things. And often it means helping with some other health plan that hasn't seen the light yet, but it is definitely there. And we've certainly heard that. And we've certainly, if you watch the video that Paige mentioned, there is definitely real dollar benefit, but there's also that intangible dollar benefit of loyalty and patients that really feel that, hey, this is a much better experience. I don't really want to go back to the way it was.
Yeah, I think for
Right.
some extended period of time, we're going to see higher costs as we try to figure out the implementation, make sure we're solving the problems. But certainly the hope is as we perfect this and move it along, that we can be in a better position from a cost point of view. I see a question there from my boss, so we don't need to answer that. I'll talk to him this afternoon.
Well,
I could not help myself, and I have to say hello to Paul, and I have to say hello to Tom, both current and former colleagues. But maybe my parting question is just, is there any problem you wish OODA could solve? Is there something hanging out there that it's not delivering to you yet?
Well, we've alluded to a few of those things in terms of the other administrative challenging items, such as the pre-certs, pre-authorizations. Just making sure that we have, if you think about the root of all evil in billing systems, it's front end demographic information, et cetera. If we get that wrong, all bad things happen after that. And so if a patient's already a part of this program, figuring out, how can we make sure that the demographic information that Blue Cross Blue Shield already knows about that patient matches the information we've got, and just eliminating duplicative requests of the patient, but also making sure that you got the actual information correct. So I think there's a lot of other applicability around these sort of administrative transactions that just take effort on our side, take effort on their side, and frustrate the patient. The patient really would like to be able to just do what they want to do fairly easily. And once they put the information in their phone, they'd rather not actually fill out another form or do it another way. They like to just have it go. And I think the potential is there as we roll this out for us to get more and more of those things streamlined to where they do it once and they're done.
And I think the biggest challenge is making this more applicable to a broader population within, the delivery system. We're starting here, but expanding it to, if we had to have 90 different apps with 90 different organizations, it would be very difficult on us. So I think expanding that would be a plus.
Well, this has been wonderful. And thank you all. Thank you, Doug Watson, Paige Rothermel, Paul Briggs. Thanks for being here today, being so frank about your journey. We look forward to checking back in with you along the way. And thanks everyone for joining us. So again, thanks so much for sharing your story today.
Thank you, Janet.
Yes, thank you
Thanks.
for the chance to do this.
Bye, everybody.
Thanks, everyone. Bye-bye now.
Take care.